Hi, I'm Jared Gardner, and this is part 2 of the normal skin histology immunohistochemistry video series, and I'm just going over some different immunostains in the skin and talking about the way they normally stain the normal skin structures. So this stain we're picking up on here, if you haven't seen part 1, you can click the link that'll pop up in the upper right hand corner if you're on your computer, and you'll be able to see part 1 of this video series to catch that. Okay, so this stain right here is p63. p63 is a nuclear stain that stains keratinocytes. So you can see beautiful nuclear staining here of the keratinocytes. And it also stains the nuclei of a lot of other adnexal structures in the skin. So it stains the hair follicle epithelial cells, which are closely related to keratinocytes at this portion of the follicle. And as you go down the follicle, you can see the sebaceous glands kind of coming off of the follicle here. And it nicely stains the basal layer, the germinative layer of the sebaceous gland. But you can see that it only to a lesser extent stains the mature sebacites. They're either weakly positive or negative. But the basal layer is actually nicely positive. And then the other thing that we can look at are the eccrine glands and ducts. And as we saw in the first video when we looked at the different types of keratins that are present, I'm going to turn the slide around. I'm having trouble driving it with my left hand again. Okay. So the different types of keratins show different staining in different parts of the eccrine secretory system. And so here you can see it's a little bit weak. It's hard to get the light quite right on these immunostain videos. So these little structures here are the glandular portion of the eccrine coil. And you can see that most of the cells in there are actually negative, but these cells are on the outside. The basal layer of cells, or the myoepithelial layer of cells, they're nicely picking up the p63. And then as that moves up into the duct, you can see that those p63 positive cells become more concentrated, and there are a lot more of them as the duct moves up towards the surface. I think there's another duct over here somewhere. Yeah, here's an example. So this is part of a hair follicle and sebaceous gland, but here's an eccrine duct. And again, you can see that inner layer is not really staining. Let's see if we can get it to pick up on the video. The background, the negative stuff is hard to show on the video because of the light. And then the basal layer, the myoepithelial kind of outer layer, stains here in the eccrine system. So p63 and its closely related stain p40, which is basically an isoform of p63, stain many of the epithelial structures, if actually most of the epithelial structures in the skin. And they're really useful because basal cell carcinoma, squamous cell carcinoma, and a wide variety of adnexal tumors, both benign and malignant, will express p63 and p40. So it's one of the most common stains that I actually use in my practice as a dermatopathologist. So that's p63. Now this stain is just beautiful. This is EMA, epithelial membrane antigen, and I believe the other name for it is MUC1, MUC1, which is something that I didn't know until just relatively recently. And so sometimes I think on exams people like to use alternative names for either diseases or stains. That's what I hear at least. And so it's good to know all the different names for things when you're getting a test maybe. I have no inside knowledge. It's just what I hear. So if I were writing test questions, that's what I would do to be tricky. I'm just kidding. Okay, so here are the sebaceous glands beautifully stained with EMA. And you can see that the EMA not only strongly stains them, but it really stains their cytoplasm in a way that makes the vacuoles, the bubbly lipid vacuoles, stand out. Like it has highlights the membranes around each individual vacuole. It's really just a gorgeous stain. One of my favorites, really, in looking at sebaceous glands. Very pretty. So the EMA staining there in the sebaceous gland, that's one thing. You can look, the epidermis is mostly negative for EMA, although you can see over here, sometimes you can have some weak, patchy expression of EMA in the epidermis. And I think that's important to keep in mind because EMA is often used as a marker to look for some sweat gland tumors and we'll show you why in a minute, but it can occasionally stain. I mean, a fair subset actually of squamous cell carcinomas will pick up some EMA. So this was the squamous cell carcinoma I showed in part 1 of the immunostains video series, and you can see that this squame is actually picking up some EMA. So if you wonder, sometimes we use EMA as one of our different markers to help us tell if something's a sebaceous carcinoma or a squamous cell carcinoma, and none of those markers are totally perfect. They all have their weaknesses. But when you're looking in a sebaceous carcinoma, what you want to see are those actual bubbles that are highlighted by EMA, like I showed you in the normal sebaceous gland. And here, this is just cytoplasmic staining, so this by itself doesn't mean something is sebaceous. All right, so squames can have EMA expression sometimes. So here, that's the beautiful sebaceous glands. It's hard to look away from them, they're so pretty. Now, here's the other thing that EMA is cool at doing, and it will highlight parts of the eccrine glands and ducts. And here in the glandular portion of the eccrine coil, the secretory portion, you can see that the EMA is highlighting not all of the cells, but it's actually really highlighting that membrane that lines the inner lumen of the duct, that the apical surface of the secretory cells are really strongly highlighted. And then as the gland moves into the ductal component, you begin to get some highlighting of the basal layer, the outer layer of cells as well. But this pattern right here is helpful because in some tumors that are of sweat duct origin or sweat gland origin, the lumens can be highlighted by using EMA to highlight the secretory lumens, and that can give you a clue that you might be dealing with a sweat gland tumor. Again, none of these things are perfect. CEA, carcinoembryonic antigen, can be used in a similar manner. So here's some more. This is probably even better highlighted here. You can just see beautifully the apical portion, the inner lining of the lumen of that eccrine gland right there is staining. Very pretty. So that's what EMA does in eccrine glands. And then one other structure you can use, and I find that when I'm looking, if I'm looking in, say, soft tissue, and I want to use EMA for a soft tissue tumor, and I don't have any epidermis present, one nice internal control that you can use are nerves, because nerves are surrounded by a layer of perineurium, and perineurium is positive for EMA. So here is EMA beautifully staining this layer of perineurium, and the inner Schwann cells and axons, those are all negative, but the perineurium is positive. And so you're often going to find some nerves in most pieces of tissue, unless it's a very small piece of tissue, and the nerves will have perineurium around them, and you can use that as your control. So here, right next to this follicle, these are a couple little nerves here, and you can see that they're outlined by EMA. Claudin 1 and Glut 1 are two other stains that nicely stain perineurium as well. So we use those in soft tissue pathology when we're looking for perineurioma, and again, you can use them here as a nice example of a background control, an internal control to show you that the EMA stain is working. So that's a pretty nice example of that. So that's EMA in the normal skin. Again, one last look at the beautiful sebaceous glands. Very, very pretty. All right. Now this stain here is not staining much of anything. You can see that the epidermis is totally negative. All the adnexal structures are negative, but these big bundles of spindle cells here are positive. And these are erector pili muscles, and so this stain is Desmin. Desmin is a intermediate filament that's present in smooth and skeletal muscle, and so you can see it here as a beautiful stain highlighting this the erector pili muscles. Okay, and I think down here we can see it in this other section as well. Here's some erector pili, and here. And the other place in the skin that you have muscle is in the walls of vessels. But I find in my experience that the muscle in blood vessel walls stains with actin pretty well, but it's much weaker or even sometimes negative for Desmin. So I'm trying to find an example here of a vessel that's picking up with Desmin, and I'm really having trouble finding one. There may be, here, let's see. Yeah, for example, here's a vessel wall. And you see almost no Desmin expression here. It's almost totally negative. So I find that looking for the muscle of a muscular vessel, that looking at it with smooth muscle actin is going to highlight it much better. But Desmin is a much more specific stain for muscle because myofibroblasts will pick up actin and other things can pick up actin as well. So I recommend to people, to my trainees, to not use smooth muscle actin by itself if you're trying to diagnose, say, a smooth muscle tumor. It can be used, but you really have to know how to interpret it. It has to be really strong and diffuse. But in general, I like to have Desmin positivity for a definitive diagnosis of a smooth muscle neoplasm. So even though we're not really talking about neoplasms in this video, I think that's an important take-home point. I've multiple times seen people overdiagnose something as a leiomyosarcoma, for example, purely based on the fact that it had actin expression. Or I've seen people see actin expression in, say, a dermatofibroma or something else and think that it must be a muscular thing because it has actin. Just remember that actin is a great stain in certain contexts, but it's really nonspecific. Desmin is my stain of choice when I'm looking for myogenic neoplasms. One other thing I'll point out about Desmin, and I talked about this in the immunostains part 1 video, is look what it's doing. It's highlighting these scattered cells in the dermis. I mean, these cells aren't smooth muscle. What on earth could they be? Well, like we talked about in part 1, these are mast cells. And you can tell, I think they stand out a little better here than in the previous example I showed. These mast cells, they have a little oval nucleus and they've got granular cytoplasm. The granules don't really show up nicely on the video, unfortunately. And if I turn up the light, it'll wash them out too much. But mast cells pick up a lot of different immunostains non-specifically, and the stains I see it most with are pan-cytokeratin, Desmin, myogenin, and MART1, and I'm sure there are others. And it doesn't happen all the time, and it's very frustrating because I don't understand why exactly it happens because it's variable. Someone may have written a paper on this. If you know of some good literature, please feel free to post a link in the comments down below because I've heard multiple explanations and none of them have fully satisfied me. But in any case, I'm not sure why it happens, but it definitely does happen, and recognizing that this pattern of scattered, kind of granular looking cells picking up a stain that doesn't really make sense, that's what you're going to see in mast cells that are non-specifically picking up stain. And then this is those are some smooth muscle cells that are kind of distorted there. So we have erector pili and Desmin expression. Let me show you an example of actin from a different case, actually, that I just had handy here. So here in this skin, you can see this is smooth muscle actin. And the smooth muscle actin, this is using a red chromogen. So immunostains can be done in brown or red, and there are some other colors that are available, but not widely. And so here are the erector pili, beautifully staining, just like they did on the Desmin. But look also in the background. Well, if I can stop moving the slide. Each individual little vessel here is wrapped by a thin layer of actin. So these are pericytes around these small vessels. Pericytes are modified smooth muscle cells that wrap around small vessels. And then larger vessel walls are going to actually have a full muscular layer, and that's going to be positive for actin as well. As we go down here deeper, we can see in the subcutis, you can see here this is kind of a triangular shaped, kind of funny squished vessel, and it's got a nice layer of smooth muscle actin in the muscle wall. Here's another one. This vessel has been burned by cautery a little bit, but you can still see the outer muscle is staining, and the endothelial cells are negative, even though they've been, again, crushed and burned a little here by cautery. Oh, here, this is better. You can see also, again, the muscle layer staining. The inner endothelial layer is actually negative on actin. So actin's a nice stain for vascular smooth muscle. And the one other thing in the skin that actin will stain, we can see it right here. This is the eccrine coils again. The eccrine coil, the outer basal layer, has myoepithelial differentiation, which means it has some component of muscle type proteins in it. So in this case, actin is present here. Now, actin is not a great stain for myoepithelial tumors in the skin, unfortunately, and that's a whole other complicated discussion that we'll have to save for another day. But normal myoepithelial cells in the basal layer of the eccrine sweat coils actually really nicely stain with smooth muscle actin much of the time. So that's actin staining in the myoepithelium, in the basal layer of the eccrine coils, and in the erector pili muscles, and also in the muscle of the muscle of vessel walls and the pericytes around small vessels. Smooth muscle actin. where's the tissue there? So this stain right here is kind of staining a lot of stuff. The epidermis, you can see, and the adnexa are pretty much negative here. But the dermis is diffusely positive. All sorts of spindled and stellate cells all throughout the dermis are positive. This is CD34, and I think I wanted to show this part right here because this is important. CD34 is a useful stain in certain contexts, but you got to be really careful with it because it stains a lot of different things, particularly fibroblastic proliferations of all different sorts can be CD34 positive. So dermatofibrosarcoma protuberans is CD34 positive, and people often use CD34 as a marker to look for DFSP, but you have to remember that a lot of other spindle cell tumors express CD34, vascular tumors usually express CD34, and most importantly, the normal dermis has strong CD34 expression. So if you try to use CD34 to look for margins on, say, a DFSP, boy, you're going to have a really hard time actually telling apart normal dermis from the tumor itself, okay? And I'll make a video on DFSP at some point in the future, and once I do, I'll post the link down below. So the dermis has a variety of fibroblasts and some dendritic cells, and it picks up lots of CD34, as you can see here. Okay, so that's one thing. The other thing is that if you look at a blood vessel, like right here, you can see out around the outside of the blood vessel, the muscle layer is negative, but the spindle cells in the dermis are kind of wrapping around the vessel and they're positive. And then the endothelial cells lining the lumen of the vessel, they nicely stain with CD34, and they'll stain with other vascular endothelial markers like CD31 and ERG as well. Okay, so they do stain endothelium, but they stain lots of other things. Here, these are the eccrine coils, and you can tell that they're totally negative. All their cells are negative. All the staining that you're seeing here is the layer out on the outside, the layer of stroma from the dermis that's wrapping around the outside of each individual part of the eccrine coil. And then these are vessels here, right next to it, and you can see the nice endothelial lining of the vessel staining with CD34. One other kind of interesting thing that's probably not of great importance in general practice is, again, I mentioned that the hair follicle structures are really complicated, and we're not going to really go into them, but look, CD34 does actually stain the outer root sheath, this outer layer that looks like piano keys, in the root portion, or the portion below the hair bulge that goes down to the root of anagen hair follicles. There's nice membranous CD34 staining in this area, which is just kind of an interesting finding that all the other epithelial structures here are negative, but this outer layer of little piano key looking basal layer of the outer root sheath is actually positive for CD34. And then here, let me show you one other thing here. I mentioned that we're not going to really talk about the spindle cell tumor that's here because it's kind of an unusual, complicated case. Here's the spindle cell tumor, and all you can see that the tumor cells are dead negative, okay? Totally negative for CD34. All that you're seeing here are little thin compressed vessels. These little stains are vessels here. And those vessels are trapped in the tumor, but the tumor cells are actually negative. And if you look, watch what happens as we move from the tumor out towards the normal skin. You start getting strong staining for CD34 once you leave the tumor and get out to the outside skin. So in dermatofibromas, for example, when people use CD34, sometimes they get concerned because they'll see this strong staining around the edge, and you have to recognize that's just the dermal cells that are CD34 positive kind of bunching up against the edge of the tumor. But when you go to the middle of the spindle cell tumor and you subtract out the vessels, everything that's left is pretty much negative. That means that the tumor is CD34 negative. That's the way that you decide if a tumor is CD34 negative or positive. Here, I think I have a DFSP actually handy right here. Now this is just a chunk of dermatofibrosarcoma protuberans with no normal around it, but you can see this is tumor. All of this is tumor, and it's diffusely positive, and it's infiltrating and entrapping adipocytes with that classic honeycomb pattern. So this is what CD34 looks like in a DFSP, and again, that's a topic for another video. And lastly, we'll talk about Factor XIIIa, which is a stain that I do not really use much at all for spindle cell tumors, because it also has lots of dendritic cells that are scattered throughout the dermis and stain. And these cells tend to be increased in number in dermatofibromas. So some people like to use it, but it stains lots of other things. Like, for example, this is a spindle cell carcinoma, and there's tons and tons of Factor XIIIa positive cells scattered in this thing, but it's not a dermatofibroma. And the other thing, interestingly, and it only works with one clone, this is a clone that's called AC-1A1. That clone of Factor XIIIa does this really unique thing where it stains strongly the nuclei of sebaceous. And so that can be useful in looking for sebaceous differentiation in sebaceous tumors. And that was something that I noticed when I was a fellow, and I noticed it because of looking at controls, and I did research and practice, and we recently published on that in the Journal of Cutaneous Pathology, and I will post the link down below. So thanks for watching. Please subscribe and click like below. Thanks so much.